This is a very important concept to understand, that there is nothing like stable heart failure. Or for that matter, now we know not even a stable coronary artery disease. But 20% of the stable patient, so-called stable patient in paradigm heart failure, had a primary event, and 17% died during the course of the trial. So of the so-called stable patient who experienced primary event, the death preceded the heart failure hospitalization in 51%. So it is not as if you would be able to predict, because the first event that occurred was death. And 60% of these were sudden cardiac deaths. So in these so-called stable patients also, there were not like the patient gradually deteriorating, giving you multiple warnings, but it was the first event itself was like a sudden death. And therefore, there is what we understand now is that there is nothing like stable heart failure. One day, this stable heart failure is going to land up into an event. And if it is going to land up into a serious event, like, of course, like death or sudden death, then we want to prevent that. And therefore, ARNI should be started as early as possible in the management. So this is the 2022 AHFSA guideline for management of heart failure, which includes in the class 1A category that patients with HFrEF in NYHA class 2 to 3, the use of ARNI is recommended to reduce morbidity and mortality. Now, only when ARNI is not feasible, then you can use other agents in patients with previous or current symptoms of chronic who are intolerant to ACE inhibitor because of cough or angioedema. And when the use of ARNI is not possible, then ARB can be used. So this is very important that now ARNI is the drug of choice. It is only when it is not possible that the ARNI should be replaced by an ACE inhibitor or ARB. Now, is the de novo heart failure separate or different from the acute decompensation in a chronic heart failure? So you can see the phenotypes in the decompensated heart failure. Those patients are relatively older population who have a known history of an underlying heart disease or heart failure. They have multiple comorbidities like diabetes, ischemic heart disease, COPD, previous stroke. They might have undergone previous interventions or bypass surgery. They usually are triggered by events like withdrawal of medication or resistance to medication, other precipitating factors like infections, cardiovascular complications, and certain drugs like alcohol and digitals. So clinical presentation is, of course, more like congestive failure. The main pathophysiology is the pulmonary and systemic vascular congestion. Now, if you look at the de novo heart failure, obviously they don't have a previous history of heart failure. They have less incidence of comorbidities. The trigger events are usually either ischemic or a valvular incompetence or inflammatory or toxic, and they present with acute pulmonary edema. And the main pathophysiology is the systolic dysfunction causing acute hemodynamic consequence.